Hello everyone, and thank you for joining us for this Health Economics and Policy Seminar, which is hosted by the Real Unit. And so to first just introduce you to who we are as the Real Units, get these slides going. The Real Units are funded by the Health Foundation to undertake research and economic analysis for the long term. And there's two units. There's the Real Demand Unit hosted out of Oxford, which is looking at long-term issues in the demand for health and social care. And the Real Supply Unit is led out of here in York, and we're focused on long-term issues relating to the supply of health and care in England. And the focus is on the long term, so we're interested in systemic issues and opportunities rather than the current crisis or acute needs. And our aim is to use economic research to support policy and action that improves the equity, resilience and sustainability of health and care provision in England. But as part of that, we understand that just generating more information is insufficient on its own. And so part of the Real Unit's focus is on engaging with stakeholders and people working and affected by the health and care systems to understand what the priorities are and how economic research could help and where it will have the most impact. And as part of that engagement and as part of that learning between researchers and policymakers, emerged this Health, Economic and Policy Seminar Series, where we like to invite people who got a lot of experience working within the health and care policy making area, so that as researchers we get to hear about their experience, about what works in practice and where economic research can contribute. So today, for the Real Supply Unit's inaugural seminar in this series, we've got the pleasure of hearing from Dr. Brendan Collins. And Brendan has worked as a health economist in a range of areas in the NHS, in local authorities, and most recently is head of health economics in the Welsh Government. He specialises in public health, and you're going to hear more about some of the work that he has been involved in around things like food policy and drug use and the COVID-19 pandemic as part of his seminar. So I'd just like to welcome Dr. Brendan Collins and pass over to him for his seminar. Thank you.
Thank you. Thanks, Susan. Thank you for asking me to do this. Thanks for giving me such a warm welcome to York today. Thanks for those of you in the audience who braved the cold and snowy weather today, and thanks for those of you who joined online. So in this presentation, I'm going to talk a bit about me, so talk a bit about my background, talk about policy interventions for health and their potential, talk about using health economics in local governments and in the NHS, turning local work into international work and influencing national policy. Talk about my experience of using health economics in Welsh governments, in particular the example of adding economics to COVID-19 policy modelling. Talk a little bit about work that I've done with UNICEF. So recently I've been working as a consultant for UNICEF around social return on investment of interventions around the triple burden of malnutrition, and talk about different methods that people are interested in. So social return investment versus cost benefit analysis versus cost utility analysis, and then give my idea of a sort of a way forward of how health economics can help in driving policy by providing evidence for policymakers. And just a disclaimer that here at the bottom, these are my personal reflections. So a big thank you to all these people who've helped me over the years, including Richard Cookson, who's here in the audience. And yeah, lots of other people as well who've helped me or believed in me over the years. And some of the people contributed to this work as well. So my research interests are particularly around cardiovascular disease and food policy. So a lot of work I've done has been around cardiovascular disease prevention. And I've got sort of, a kind of personal interest in that as well. So my dad had a heart attack when he was 48 years old. I'm now 42 years old. So I'm kind of thinking, ugh. So need to be healthy. So I think the need to be healthy, is really important. And I'll talk a bit more about that. I'm also interested in drug and alcohol treatments and prevention. So I led on work for NICE around preventing drug use in vulnerable groups. So modelling for NICE, interested in cancer, dementia, getting more interested in kind of global public health. So the work that I've done for UNICEF has got me really interested in that, and also infectious diseases. So particularly around the COVID pandemic, I got interested in infectious diseases, and I was working within health protection in Welsh governments. So that's me. So if you're working in these areas and you want to work with me, then these are the things I'm interested in. So a little bit about me. I'm just being a bit indulgent here, but I grew up in Norris Green and Croxteth, which are deprived parts of Liverpool. They had a big heroin problem in the 1980s when I was growing up. I was one of 6 children. I got a scholarship to a private secondary school, and I think that changed my horizons a little bit. I went to Liverpool University as an undergrad, initially studied English and then switched to psychology and neuroscience, which I think was a really interesting subject and probably one of the only subjects that was kept me captivated for 3 years, because I think I get bored very easily, which is probably why I'm a bit of a magpie working across different things. I did Masters in Public Health at Liverpool John Moores University while on NHS Trainee Analyst Scheme, postgrad certificate in Health Economics at University of Aberdeen, and then I did my PhD. So my PhD was around combining economic modelling and realist evaluation to evaluate local public health services. I got really interested in realist evaluation, and there's a burgeoning field around realist economic evaluation methods at the moment, which I think is a really interesting area. And then I've done a teaching qualification more recently as well. So I've had quite an unconventional career. I've worked in the National Health Service, worked in local government, I've worked in academia, I've worked in Welsh Government, and more recently as a consultant for UNICEF. So I've had quite a kaleidoscope career. I'm currently a trustee for the Health Equalities Group, which is a charity based in Liverpool, which includes Food Active and Healthy Stadia, which is around improving people's health and reducing health inequalities. So I was going to talk a little bit about the effect of fortune on things. So when I was on holiday in Barcelona with my partner, who's now my wife, and I decided to go to this big data exhibition, and it inspired me to write this paper about big data and health economics. And when I had my PhD viva, one of my examiners said, the only reason I passed you was because I read this paper on big data and I thought it was quite good. So sometimes you do things for, like, you feel like, why am I doing that? But it kind of creates a little bit of fortune for you, because it doesn't really seem rational that I was kind of, my partner didn't want to go to this exhibition. So it was just like, you can go to it on your own, pay for an exhibition. A lot of it was in Spanish, and I don't really speak Spanish. But sometimes these kind of things, I think sometimes good fortune kind of comes back down the line towards you. So sometimes if you think you're doing something and you're not sure why you're doing it, then sometimes maybe it's creating a bit of good fortune for you in the future. So I'm here to talk today about using health economics in local governments and devolved administration, so particularly around Welsh governments. So I worked in East London. So in East London, I worked across local governments and the NHS. So I was working for City and Hackney, Newham and Tower Hamlets. So four local authority areas, although City of London's a very small local authority area. I'm now involved in the Liverpool Health Determinants Research Collaborative. So there's all these HDRCs that have been set up across the country, which I think got real promise in terms of working with local governments around improving health and thinking about the impact of wider determinants on health. Now, there's not many health economists in local governments. There's only a few that I've known of over the years. There's people who've done similar roles to me, but I think there's real potential to do more health economics in local government. So my work was mainly based in public health, and it was evaluating public health programs. So things like smoking cessation, drug and alcohol treatments, weight management, things like health trainers, and looking at neighbourhood investments, the impact of neighbourhood investments as well. Sometimes I was producing bespoke models, but often using existing return on investment tools. I think there's not as many of these return on investment tools that have been produced in recent years, and I think that they do have real potential. So I think one thing for health economists is, if you're doing a piece of work, maybe you could produce like a tool or a user interface that sits on top of it. I think that can be really useful. And I was involved a lot around recommissioning services. So I think services would quite often see me come in to do an evaluation and think that I was kind of the angel of death for their service, because it was quite often that they might be recommissioned afterwards. And the commissioning process in local government was on a kind of 3-year cycle. So they're meant to recommission every 3 years, but sometimes they could extend for 2 years. And I think sometimes this was useful, but I think not always, because I think sometimes you kind of need to give services time to improve, and you need to kind of stir the coffee before you add more sugar. And I think that what happens if you recommission the service as well is that a lot of the staff just cheap you over to the new service, and you might end up with slightly different leadership, but you end up with a lot of the same people as well. So I'm not always sure this was a good way of doing things. And then a lot of work I was doing as well was sort of working with NHS around service redesign. So things like urgent care, redesigning local urgent care services, or involved in what was at the time local sustainability and transformation plans. So what evidence was going into those plans around different interventions that they wanted to do, like improve diagnosis of hypertension or have alcohol teams in hospitals. And quite a lot of work I did as well was around prioritisation, so using multi-criteria decision analysis. And I've used multi-criteria decision analysis quite a lot in Welsh Government as well. So I feel like MCDA maybe is used more than people realise in government, but that it doesn't always make it into the academic literature. And I know that people have different opinions about it. So I think that possibly UK Treasury were not always in favour of it, or people here in terms of health economics are not always big believers in terms of MCDA. So yeah, I said that quite often we use these kind of value for money type tools. So we were kind of plugging in data into these tools. So there were these tools that were produced by the National Social Marketing Centre, which were Excel-based tools around behaviour change. They're still available online, but they've not been updated for some time. There were also tools that were produced by NICE, but they're no longer available online around public health interventions. So I think there's probably a gap in the market for these kind of tools to either be reproduced or be updated, because I think they are useful in terms of making the case for cost effectiveness and return on investment in local areas. So some of the challenges with these kind of tools, I think, are things like data requirements. So what kind of data do you need for them? Do people have the technical skills to be able to use them? There's questions around granularity. So you can have a tool where you can have really granular data, but do people have that level of data, or should we just go for simplicity in terms of the inputs, but then it's more generalized rather than specific, say, to the context that you're working with. There's issues of shelf life as well. So if you produce a tool, how long does it last for? And then I think there's sometimes issues around how do you explain the results to decision makers as well, and what are the priorities for decision makers. So I think in local government, public health sits in an unusual space, because a lot of the time they're saving money for the NHS rather than saving money for local government. Some of the interventions would save money for local government, things like if they've got social care cost savings, but a lot of the time I think a lot of the savings fall to the NHS. So you've got this kind of cross-sector flow problem where you spend money in one sector of public sector or the economy, and you get benefits in a different sector. So a lot of the work that I did in local government involved modelling. And there's this question about, should local government create economic models themselves? So sometimes when I was doing this work, people would say, well, shouldn't NICE be doing this kind of thing? Why should like someone local be sort of doing this, like, or doing a very provincial model for their own area? So I think one way forward might be to have a kind of federated model where different local authorities with expertise lead on different things, or have a shared modelling platform where they can put stuff in one place. And these are completely hypothetical, but I think having basic estimates of the value of different outcomes. So if a smoking quitter is worth £5,000, or a person who's no longer obese is worth £10,000, I think having those kind of values to compare the cost of your service to would be really useful. So I think sometimes it's kind of produced in these simple results that could be produced from economic evaluations, but they're not always available to people in local government. I think we need a lot more around wider determinants. So the HDRCs that I mentioned are around health determinants. I think thinking about things like health outcomes and housing. So if local government is improving housing situation, what are the health outcomes attached to that? Because we don't always have that kind of evidence. And there are projects like this TRUDE project, which I think is producing some useful tools for this. So they're producing something called the house tool, which I think is useful for house builders, etc. So this is an example of the type of model that I would do in local government. This is using Simulate software. It looks like it's a very complex model, but a lot of it is just kind of ways into the service and ways out of the service. So the kind of turquoisey box on the right is ways into the service, and then the pink box is on the left is ways out of the service. The actual bit in the middle is not that complicated, but it was looking at time that people would be in service, and then quality of life and costs incurred. And then we produced results saying what the costs and qualities were over time, and we estimated the cost effectiveness ratio. So the cost effectiveness ratio was around £6,000 per quality, so it was pretty cost effective. And that was only really morbidity rather than mortality impacts as well. And then we projected future demands for the services as well. I think this was useful for policymakers in local government, because they were hoping that demand was going to go down over time, but we showed that based on the current levels of throughput, it was likely to either increase or be pretty stable over time. So they couldn't necessarily reduce the size of the service without having to reduce what they were doing. So it's one example of kind of modelling that we do in local governments. And I think what happened when I was working in local governments, public health was that I kind of became more aware about how policy interventions can improve health and this effectiveness hierarchy. So if you've got sort of national policy interventions like fiscal interventions, they can have a bigger effect rather than individual agentic interventions. So say thinking about obesity, national policy interventions around creating a healthy food system can be much more effective and potentially more equitable than individual kind of counselling or weight management services. I think there's a huge impact of other potential policy interventions as well. I think this has opened my eyes in terms of thinking about my future work as well. So one thing that I worked on was the sugary drinks duty, which started as a local project, and we ended up doing it nationally. So there's questions about when should government intervene. So I guess economists might say the government should intervene in terms of cases of market failure. So in the case of sugary drinks, behaviours based on imperfect information. People don't appreciate the amount of sugar that's in their drinks and health risks. There's also heavy marketing and time preferences. So people prefer to experience pleasure now and not worry about the future. I think in terms of how governments react to this or how they produce policies, it might vary in terms of how technocratic they are, how they listen to evidence, or how much they're worried about being seen as pro-business versus public health. I think arguments based on impacts on children tend to land well with policymakers. So if you make arguments around child obesity, child dental health, then I think that can land pretty well. So the work that I did on sugary drinks started off as a model for the northwest of England, produced for Food Active, and then it was extended as a model for the whole of England. And it was cited in this report called How the Sugary Drinks Tax Was Won by Sustain. Now, I think I wasn't the only person to do modelling of this, and probably other people did more robust modelling than I did. But it was definitely kind of creating this tool and creating this model, I think, did have some impact in terms of the sugary drinks tax. And before I started on this work, I thought there was no chance that a sugary drinks tax would ever kind of be implemented in the UK. So I think it was interesting in terms of policy. And like my family and friends still talk to me like about being the sugary drinks tax guy type thing. So yeah, I mean, I don't really claim that much responsibility for it. But so we produced this tool which gave results by local authority, and you could have different levels of duty, and it would tell you what the impact would be in different local authorities. So this is an example for showing Wigan. Yeah, so it was cited in this report. And one day I turned on the news. You can see it was 6:37 in the morning, which is pretty early for me to be up in the morning. And I saw that they were discussing the work that I'd done on the news, which I didn't know was going to happen. So this is Gavin Partington, who's from the Soft Drinks Association. So he's obviously against the soft drinks tax. And then it was on Good Morning Britain. This is Susanna Reid. They had something showing how much sugar is in a sugary drink, which Susanna Reid proceeded to pour into the sugary drink, making it even more sugary, kind of bubble up a little bit. So that's probably the proudest moment of my career so far. But yeah, so I've also been involved quite a lot in adding health economics to the impact suite of models. So these models started with Simon Capewell in Liverpool in 1996 with the coronary heart disease model, and it's been replicated in a lot of different contexts around the world. And it's contributed to policy discussions, NICE guidance, etc. So the initial models were sort of decomposing changes in coronary heart disease and looking at the contribution of different factors. So things like new treatments or better treatments, things like changes in risk factors, so changes in blood pressure or smoking status, and then how much of it was unexplained. And it's been done for a lot of different countries around the world. What we've got now, and this is actually the multi-morbidity work is also working with Health Foundation, is we've got a model that can look at different scenarios, future scenarios, and look at different policies as well. So we've used these models to test out all different policies around diet, or we've looked at NHS health checks as well over time. So CVD health checks that people get at age 40. And yeah, so we got I think pretty good set of models that we can use for a lot of different things. They also model inequalities as well, so we can look at health inequalities. So Chris Kipper-Dimos is one of the main people working on these models, as well as Martin O'Flaherty and Anna Head. So we've used these to test a lot of different policy scenarios, both in the UK, but also we built a US version of the model as well, looking at things in the US. One thing we looked at was salt reduction. So we had a kind of main piece of work around salt reduction, and then I had this spin-off paper looking at what are the results just for the people actually working in the food industry. So we were interested in how many cases of CVD would be prevented in people who actually just worked in the food industry themselves, because there was a lot of pushback from the food industry around these sodium reduction targets. So we were kind of showing that it wasn't necessarily cost neutral for them, but that you could see that even for those people working within the industry, it would have benefits as well in terms of CVD cases that were prevented or postponed. And we had different categories as well. So food system was a broad category, and then processed food was more specific. And then we had ever workers, so people who'd ever worked in their lives, and then current workers. So I'll move on to talk a bit about health economics and Welsh Government. So I joined Welsh Government in around January 2020, which my main idea was kind of to work on health economics, to look at having an efficient NHS in Wales. I was quite excited about Wales because the health boards have got public health and primary care and everything all in one place. So I think it's quite an opportunity for the NHS to work together. It's a bit, I mean, now that we've got integrated care systems in England, it was a bit like a prototype for future integrated care systems, but I thought it was a real opportunity. Then what happened was kind of COVID came along 6 weeks later, so I kind of got roped into a lot of stuff around COVID, which I'll talk about in more detail. But these are the main things that we do in Welsh Government. So quite a lot around impact assessments. And before I worked in government, I thought impact assessments were quite exciting, right? I like to read them and stuff like that. When you're in government, people don't always like doing them. People don't always want to do them. So if you want to do impact assessments, you'll be very, very popular. But yeah, people don't always seem to like to do them. I'm working on a lot of business cases. So we were changing services like ophthalmology services. We were making some big changes to them. So I would work on a business case of what would change over the next few years. Quite a lot around cost effectiveness of programs and interventions. So looking at new vaccines, so things like the RSV vaccine or chickenpox vaccine. We'd look at cost effectiveness. There'd be usually work that would be done by DHSE or JCVI, and then we'd be building on that and then looking at what it meant for Wales. And quite a lot around prioritisation, so programme budgeting and marginal analysis and multi-criteria decision analysis. So trying to prioritise investments within government. A lot of modelling, including COVID-19, which I'll talk in more detail, and then looking at government investments. So things like things where investments might have an impact on health. So let's say hypothetically someone's building a nice kind of a new ice cream factory that's making like really expensive ice cream, like really classy ice cream, and they say, well, we could either build it in Wales or we could build it in England, and we want some government support for it. So we want a few £1 million from Welsh Government to build this ice cream factory. It's those kind of questions where you can say, well, it might be good in terms of stimulating the economy, but is it good for health if it's an unhealthy food? So those kind of questions that I would get involved in a little bit. And there's quite a lot of talk around the relationship between health and other outcomes. So health-related worklessness, things like deaths of despair. So if you've got a recession, then what would we expect in terms of deaths of despair? So deaths from suicides, from drug and alcohol problems. So they're the main things that I was involved in. I mean, we had a very, very small health economics team in Welsh Government. So Scottish Government, I think, has got quite a few more health economists than we got in Wales. Northern Ireland, I think, has got almost none, maybe none. But in England, you've got quite a lot of health economists in DHSC, but I think also in places like OHID, Office for Health Improvement and Disparities. So you've got health economists in different places. I'd say overall, if you're a health economist, if you have a chance to work in government, definitely do it. It's a great opportunity, and it'll be a lot of fun. I think the main skills for working as a health economist in government are things like diplomacy. So you need to be diplomatic. You need to check that you're not cutting across other people's work. Building credibility with people, so showing people that what you can do. I think the way it works in government is if you don't have that credibility with people, you can kind of be frozen out without really knowing about it. So it can be quite a cutthroat world in some ways. So I think having that credibility, I think like government and academia are both kind of pyramid schemes, right? So academia is a pyramid scheme where you find someone to give you some money, you have an idea, find someone to give you some money to do your idea, and then find someone else to do the work. Government is a bit like that as well, where you have an idea, but then you still need someone to do the work as well. You don't necessarily always need to find someone to give you the money as well. So it kind of cuts out that bit. But I think they're quite similar really in terms of being pyramid schemes a lot of the time. So if you have an idea and have someone to do the work, then you'll be in a good place. I think quite a lot of what happens in government is rapid evidence synthesis. So it's combining evidence from different places and trying to make a judgment, trying to influence decisions. And so I think having those evidence synthesis skills are really good. And I think for me, I'm probably not a marathon runner. I'm not like the smartest person in the room, but I think I'm quite good at sprinting and finding a load of evidence on something in half an hour or an hour if I need to. So I think having those kind of skills can be good. I think people move around quite a lot in government, so understanding new topics quickly and being adaptable is really, really important. I think having a broad understanding of research and evaluation methods. So a lot of the time, people might come to you with like clever evaluation methods, but if you understand a bit of regression, if it's a bit like regression or interrupted time series or whatever, then I think having a broad understanding is really useful. I think often leading teams, if you're at a senior level in government, being able to lead teams and develop people is really important as well. Yeah, and working quickly. So my role in COVID-19 pandemic was leading on modelling and advanced analytics as part of the technical advisory cell. Welsh Government had devolved powers around stay-at-home orders, so you probably know that Welsh Government had lockdowns and things at different times to England. We had a modelling subcell of about 8 to 12 people, which were a mixture of different skills, so operational researchers, statisticians, etc. And we linked in with academics in Welsh universities, so particularly Mike Gravener at Swansea University, who really stepped up and helped us a lot in terms of modelling. And so my role was also presenting to policymakers and ministers and attending national groups on behalf of Welsh Government as well. And I think providing scientific advice in an emergency is really tricky. So you think about like thinking fast and slow. I think sometimes academic research can move quite slow, whereas policy has to move quite fast. So it's changing that relationship really and working out a different rhythm, I think. And also recognizing where evidence doesn't exist. So sometimes you'd have to make decisions where evidence does not exist. And, you know, you could argue that some of the things that happened during the pandemic were sort of little experiments of things that had not really been tried before. But I think also it's about using evidence in a different way. So it's not simply your evidence-based medicine paradigm or that kind of hierarchy, but things like engineering. So if you're building a bridge, you don't necessarily do a randomized control trial where you build 2 bridges and see which one falls down. So engineering is different. So it's kind of like similar evidence with face masks. I think face masks was one of the real areas of debate where the trial evidence might not be very strong, but people think, well, the physics and engineering makes sense. So we had this idea of the 5 harms. So quite often people talk about the 4 harms. We had these kind of 5 harms of the COVID pandemic, and it was really about balancing these different harms. So you had direct harms, you had indirect harms, economic harms, and inequalities. And so there's often no harm-free strategy. It's about trying to balance these. But an issue also was that the data would be on a different schedule. So you've got daily mortality data, daily case data versus economic indicators that might only be published quarterly. So how do you kind of balance those in your decision making? And in Wales, we've got the Wellbeing of Future Generations Act. So we've got this real focus on well-being as well. So that requires public bodies to think about the long-term impacts of decisions, work better with people and communities, and prevent future problems such as poverty, health inequalities, and climate change. So we have to kind of figure that into all our decision making as well. And you've probably seen this kind of thing about COVID being a syndemic. So you've got different types of risk factors overlaid on top of each other. So people if you've got a house, you've got a garden, you've got a car, you've got money in the bank, you're in a stable relationship. It was a different pandemic for you than to people who've not got those things. And there were shadow pandemics hidden as well. So violence against women and children that was kind of hidden by the main pandemic as well. So I think thinking about all of that, and we were thinking about all of those things through the pandemic in Welsh Government. So I had quite a big role, I suppose, around thinking about inequalities as well as thinking about economics and health economics. So one of the criticism of the COVID response is that it focused too much on epidemiological outcomes rather than broader economic outcomes. And I think ideally decisions need to be based on integrated impact assessment where costs and benefits are quantified as well as you can. In Wales, we quite quickly included estimates of costs of hospital activities and QALYs. Now, they probably weren't perfect. So early in the pandemic, they were based on what we thought were the most similar diseases based on clinical judgment. So things like pneumonia, the QALYs lost from pneumonia hospital admissions or community cases, asthma. We also included long COVID. So that was initially based on QALYs lost from moderate fibromyalgia. So, and I think a lot of models at that time didn't include long COVID. So I think some of the models produced by others didn't include that, which is probably not including the full impact of COVID cases. We also work with Welsh Treasury around estimating gross value added losses associated with different levels of restrictions. So that was kind of building up from different industries that we think were affected by different levels of restrictions to look at these GVA impacts. And so this was trying to sort of consider these trade-offs. And I think it's partly a technical process of, you know, you can put a value on it, you can estimate the net monetary benefit of a strategy, but then it's partly a subjective process. And you know, as health economists, we're always putting a value on health, but this is like for me, this is the sharp edge of it, really, isn't it? Is we're looking at economic indicators versus people who are going to get ill or people who are going to die from COVID. And there's that question about rule of rescue as well. So do we prioritize rule of rescue? And if we close schools or whatever, then can we rescue those children in terms of their education a bit further down the line? So there's those kind of questions. I think there's questions around complex systems as well. So individuals will change their behaviours in the absence of government intervention. You saw that in the US. So different states in the US had different approaches to COVID. But even in the states where they were more relaxed in terms of restrictions, people still changed their behaviours. People still stayed at home and weren't spending money. So this is an example of, and this is published, this is an example of where we use modelling to look at the impact of restrictions. So we had healthcare cost savings, we had estimated qualities gains, and you can see they're all rounded, and that's because, you know, we weren't that certain that we could be that accurate about them or that precise about them. But you can see we've also got the net monetary benefit and then the GVA loss. So the GVA loss is based on kind of how many industries are closed and for how long, for different levels of restriction. So L1 means basically no restrictions, and then we've got different levels up to level 4. But you can see what we've got is, and we valued qualities at £60,000, which at the time was UK Treasury valuation. It's gone up now to £70,000. What you can see there is you've got net value. So a lot of them have got negative net value. So a lot of these strategies based on the healthcare cost savings, qualities gains, and then the GVA loss, it's negative. But I think how this was really used, I suppose, is thinking about, are they in the same ballpark? So if they were out by a factor of 10, if the GVA loss was like 10 times the value of health and the healthcare cost savings, then you might say, well, this is not a good decision. And quite early in the pandemic, some people were making that argument and saying, well, you know, the health gains are worth nothing compared to the economic losses. So I suppose it was around thinking of if they're in the same ballpark, really, rather than whether or not they completely balance out. And there's a lot of other things to consider that weren't included in this, obviously. So things like educational impacts, which we also put a price on at one point. So I think we tried our best to try to understand some of these different impacts and the weighting between the economic impacts and the health impacts. And, you know, there's debate around, well, what should you value a quality at as well? So UK Treasury valuation of £70,000 per quality now. If we paid £70,000 for every quality, then we'd rapidly spend all the money we've got. So what should be the value of a quality as well, I think, is a question. So in terms of my reflections on using economic modelling in emergencies, so the example of COVID, I think considering economic impacts could be important in a range of emergencies. So, you know, there's a lot of things that could happen. Like, I mean, we look at things like flooding and potential extreme weather events and things in future, where I think understanding economic impacts as well as health impacts is really important. Putting a price on human lives is difficult in terms of ethics and human rights, but I mean, that's what health economists do, really, isn't it? But without that, then how would we make decisions? We'd still have to make those decisions anyway. There's this issue around timing. So economic indicators are often not updated very frequently, but other short-term data like mobility, credit card use, etc., might be used as a proxy for economic activity. I think there's been an increased interest in estimating economic costs of future disease outbreaks and pandemics. And there's estimated costs of things like conflicts like the Russia-Ukraine conflict. I'm going to talk a little bit about work that I've done with UNICEF as well. So I've recently been working with UNICEF around creating a social and return on investment tool around social and behaviour change programs for adolescent nutrition based on stakeholder engagement with people in Zimbabwe and South Africa. So I think triple burden malnutrition could be one of the biggest issues facing the world in the next 30 years. And this was another thing that was quite lucky. I think I was doing this work for a university in London where I was kind of going down to London. They didn't pay for my travel. I was getting up at like 4:30 in the morning. And so I was probably like basically doing it for free. And I was like, why am I doing this work? I'm crazy to be doing it. But the person that I was doing this work with then suggested me, because he'd retired, then suggested me for this work for UNICEF. So maybe that was why I was doing it. I just didn't know at the time. I think what I'm saying is I don't really say no to things very often, which I probably should do. I should say no to more things. But yeah, so I created this tool around the value of different activities. So looking at trying to split it off into different types of values as well. And there's a lot of challenges with this work. So there wasn't a lot of data, there wasn't a lot of evidence for these kind of interventions, which I was surprised at. I was surprised at the lack of evidence around interventions around overweight and obesity in low and middle income countries, because I think overweight and obesity will become one of the biggest problems in low and middle income countries, and the health systems aren't set up to deal with it. So they're not going to be able to afford the treatment of type 2 diabetes and CVD and things like that in future. Maybe if Ozempic and things get really cheap, they can use those. I don't know. So this was the process that I followed. So it was reviewing existing tools, stakeholder engagement, searching for evidence of interventions, and then creating this tool, testing it in 2 country settings. This is the example of the kind of output. So I was trying to look at benefits by different sectors. So you got health benefits. So a lot of that was DALYs. You got government and healthcare cost savings. You got productivity or employment. And then I found a bit of evidence around environmental sustainability. So carbon impacts of different types of diet. So carbon impact of a high versus low ultra processed food diet. And then we got other benefits like well-being and education. So this had a different audience because it was trying to feed back to UNICEF, but also to influence donors. So I think it's kind of saying to donors, look, if you donate this money to UNICEF, this is the return on investment that you can achieve. And it's at the moment, it's quite hypothetical, but these tools I think can be used more in future when we've got a bit more data on these interventions. So I thought talk about that a little bit. Also talk a bit about distributional cost effectiveness analysis. So we've got the DCAEA guru in the room here in York. And I think that even though it's been used a lot by people like NICE and HTA agencies, I don't think that it's taken off that much in local or national government. So I think it could be used a lot more, say, in government impact assessments than it's used in the future. So I think there's opportunity for there. So here you've got, probably some of you know about this, the health equity plane. So we're thinking about which interventions are a win-win. So are they both cost effective and reducing health inequalities? And this is an example of work that I was involved in around NHS health checks, so that we found that targeted NHS health checks were a win-win. They were both reducing health inequalities and improving overall health. And I think what we should be aiming for is a kind of win-win portfolio of interventions. So it might not be that all interventions will be a win-win, but if we've got a kind of a blob of our portfolio of interventions, then if the majority is sitting in that win-win quadrant, then I think that's what we should be aiming for. And I think that this kind of thing will be useful for policymakers in health, in government and in the NHS in terms of understanding where their interventions lie. So I think hopefully it will be used more in future. So I'm going to move on just to give some kind of overall observations and recommendations before I finish. So I think a lot of work that I've done has been around public health, and I think return on investment for public health interventions is often much greater than clinical interventions. So I was a co-author on this paper with Rebecca Masters, which looked at different types of public health interventions, prevention interventions, and it's been cited quite a lot of times. So the sort of overall estimate of return on investment of £14 for every £1 spent, even though that £14 is not financial return on investment, it's been cited quite a lot. So this paper's been cited a lot, and it was mentioned in this New York Times article, for instance. So I think everyone knows that prevention is something we should be doing more, but I think the devil is in the detail. So it's how do we do it and what do we invest in? And I think we need prevention on an industrial scale. So we need to think about what are the things that work and do them on an industrial scale. I think sometimes what happens is there's a lot of kind of local tinkering with public health interventions and sort of maybe we adapt them too much. I know that you need to adapt interventions for your local context, but I think sometimes we spend too much on that rather than thinking what works, let's do it at scale. Thinking about what do we get from social return on investment versus cost benefit analysis versus health economics. So they come from different schools of thought. So you've got kind of health versus well-being versus welfare. And I think they really differ in their methods to extrapolate from one outcome to others, or to project into the future, or to monetize the benefits. So social return on investment, I think, is good because it often has a long list of outcomes. You have lots of different outcomes in there, but it's typically quite thin method. So it's often small, uncontrolled before and after type studies rather than more robust study designs like natural experiments or trials. And there is evidence that you see a bigger SROI ratio for less robust studies. So for studies that are less robust, you normally have a bigger ratio, and I think there's a bit of a problem with SROI of people just throwing lots of stuff in there until you get like a nice ratio, basically. I think cost-benefit analysis is often carried out prospectively. So by governments, it's looking at future policies and the impact of future policies, whereas cost-utility analysis is often retrospectively, and it's often alongside randomized controlled trials of health interventions. SRI is a mix, so sometimes it's prospectively, sometimes it's retrospectively. So I think it's about choosing the methods, especially if you want to influence people in government. It's about choosing the right methods. I think maybe SROI was used quite a lot in local government by charities and things like that, but it's not used so much anymore. And there has been research on cost-benefit analysis in the US that suggests that they're not systematically optimistic or pessimistic. So they're usually, on average, they're kind of reasonably good at predicting what will happen from different policies. I think there's questions about government versus health perspective. So what value of quality should we use? Should it be 15,000 based on the health production cost in the NHS? Should it be 30,000 based on a nice threshold? Should it be 30,000 and 70,000 based on UK Treasury? What benefits should we include? Do we move more towards wellbeing valuation? So there's a lot more methods around wellbeing valuation and well-being, and some people have said that should be our maximum, that should be what we aim for as wellbeing, but I'm not convinced that we have enough data on well-being and wellbeing to be able to just use that as our overall methods. I think we need a lot more off-the-shelf tools and data and estimates that can be used more by people in local and national governments, because I think that has real potential. So probably sometimes I think people in academia think, well, you publish a paper on something, they'll read it, that will give them the information that they need. But I think having more of these tools and these kind of short policy briefings and things like that, I think is really useful. And I think sometimes there's inconsistencies with different types of health interventions about the methods that they use. So for impact assessments, they might use the JCVI ISA of less than £20,000 per QALY. Yeah, so there's all kinds of issues, I think, around how government impact assessments are done and how they value health. I think in terms of my advice for working with policymakers is try to find people in government, or they might find you. If you're doing work that they're interested in, they might contact you. And when I worked in Welsh Government, I found that academics were really good at kind of getting back to me and responding when I was interested in stuff, which was really good. And I think you can build those relationships. And I think aiming for those short summaries. So if you want to put something in front of a minister, then I think 2 pages is great. And if they need more information, they'll ask for more information, or you can possibly have like an appendix or something like that. So sometimes I think for research projects, people kind of think, oh, well, policy briefings is sort of, it's become like a bit of a cliche and it's not really useful. But I think people in government, these short policy briefings can be really useful. And if they're not useful, then your work's not useful. So I think it's important to try and do these kind of short policy briefings and try and boil things down. I think there's a lot around communicating uncertainty as well. So I think there's a problem sometimes where ministers or policymakers might think that uncertainty means you don't know what you're doing, rather than there's always, stochastic uncertainty with any kind of predictions or anything like that. So I think communicating what uncertainty means and communicating uncertainty is really important. And I think health economists are really good at visualizing uncertainty. So you've got things like tornado charts, or you've got like kind of scatter charts, or you've got cost effectiveness, acceptability curves and things like that. So I think there's a lot of good stuff that health economists do that can probably be used more widely as well. I think use cost-benefit analysis if you want to influence government. So ideally have a user interface where someone can easily vary or update the parameters, so that if something changes, they can change it easily. And I think learn from other evaluation methods. So I think social return investment has a lot to teach about stakeholder engagement and understanding what outcomes are important. And realist evaluation, I think, has a lot to teach us about understanding the impact of different contexts on outcomes. I think there's a lot in the kind of health economics value flower. So people have probably seen this quite a lot, especially health economics people, but I think there's a lot in this that can be applied to different areas of government. So in terms of what the way forward should be, I think we need to focus more around macro health economics. So a lot of health economics is an extension of microeconomics. Think about, how do we create a healthy system? What does an efficient health system look like? How do we have a healthy workforce? I think we need central government, devolved administrations, NHS and public health to work together to improve health in a cost-effective way. And I think people outside of health economics probably don't realise how much overlap there is between different methods. So you've got cost utility analysis, cost benefit analysis. They don't realise that you can probably rearrange some of the same data to do those different things with the same data. I think we've got an interesting time around QALYs in the US. So I've seen stuff in the US, recently because they do use QALYs in they did use them in cost benefit analysis in the US, and they're looking at kind of stripping out the health related quality of life and the life years gains rather than having them as QALYs, because QALYs have become taboo in the US, and there's been things against using them for healthcare decision making. I think there's a question around, should prioritization methods be seen as part of health economics as well? So PBMA and MCDA and things like that, I think, can be really useful, but health economists aren't always sort of believers in them, but I think they're really useful tools in the armory. So these are what I think the three priority areas should be for health economics and government, really, I think is around, in the UK anyway, is around having an efficient NHS, having a healthy workforce. So we've got a big problem with health-related worklessness at the moment, which started before the pandemic. So it's not just the pandemic effect, but I think what do we do in terms of having a healthy workforce? And it might be things like looking at mental health services or musculoskeletal problems, because these are some of the main things that take people out of the workforce. And I think we need prevention on an industrial scale. So I think we need health economics to making the case for prevention, and telling the story of how we do that and how we prioritize preventative interventions and looking at the schedule of benefits over time. So yeah, I think I've said quite a lot of this. I think using economics and modelling where there's a genuine decision question. So not simply to say, oh dear, or that's nice. So where there's a genuine decision to be made, I think that's where health economics and modelling is really useful. I think there's a potential role for artificial intelligence in filling data gaps as well. So matching up different data sets, doing some of the heavy lifting that takes a long time to do. And I think using health economics and government depends on understanding of its potential. So we need decision makers to understand the potential for health economics. Sometimes it's just about, oh, well, the cost per quality is less than 20,000, so it's cost effective, that looks good, or something like that, rather than really engaging with the detail of what health economics can do. And I think it also depends how technocratic government is as well, so how much they listen to evidence. Yeah, and in my experience, health economists are usually very wise people to work with. So I think they should be used more in government, both in terms of economic evaluation, but across other things as well. So that's the end of my thought. Thank you very much for listening and taking questions.
That's great, and as everyone can hear, he's had a wide range of experience, and so I'd like to invite now any questions that anyone has for Brendan. We have a microphone in the room. You could just say your name and where you're from.
All right, Niels Guttaker, University of York, unsurprisingly. Brendan, thank you for this talk. It was really insightful, a lot of ground covered. One thing I picked up on, which mirrors my own experience in this space, is that the numbers don't tend to matter as much as one might think, especially the precision of the number. Is that something you would subscribe to? Did I pick something up in your talk there, or did I misinterpret you?
Yeah, I'd say that's true for yeah, both for local and national governments. I mean, the numbers matter if something has a positive benefit, then. But I think the precision of it, yeah, I think doesn't matter so much. So health economists spend a lot of time doing probabilistic sensitivity analysis, right? And I'd say sometimes we don't always do it as well as we could because the data doesn't exist, and you spend a lot of time trying to find the distributions to do your probabilistic sensitivity analysis. And I think trying to influence policymakers, those things, yeah. I mean, if there's huge uncertainty, then that's important. But apart from that, I think probably we spend too much time on that kind of stuff. Yeah.
Well, I was going to ask a question about your involvement in the commissioning process and the 3-year cycle, and how you think people might take into account kind of sustainability or longevity into that. I'm reflecting, as part of our engagement, we were speaking with people from the voluntary VCSE sector, and they were saying they'd find it really difficult within the space of 3 years to demonstrate that they did a good job to get recommissioned. But from the other side of things, how do you view that? How do you, when you come to the recommissioning process, to establish if what's happened in the previous 3 years is worth continuing?
Yeah. I mean, I'd probably agree with people in the voluntary sector saying that. I think, and I'd be very sympathetic to them saying that. Definitely, I think it can be tricky in that time to demonstrate what you've done. I mean, hopefully, I think part of it is how the outcomes are designed that they get judged against as well. So we need to. I think we do need to have outcomes. I think sometimes in public health there's a danger that you say, well, we did this intervention and it gave everyone this intangible, warm, fuzzy feeling, and we don't have any outcomes. So I think we do need to measure outcomes, but they need to be the right outcomes. And I think it's really challenging for voluntary sector organisations because there's all sorts of rules. They have to have money in the bank and things like that before they can bid for services as well. So I think I do agree it's very tricky, and I think having a social value framework helps with that as well. So if you have additional social value points for voluntary organisations versus a big big group, you know, Virgin Health or someone like that who's coming in to provide a service, then I think that can help you to make the right decision as well.
So that might be about prioritizing people who are less advantaged in terms of demonstrating ability to demonstrate their value, maybe. Or
yeah.
Interesting. Got a question from online.
Yeah, from the Zoom. Yeah. So the first one. So what are some of the soft skills you'd recommend health economists to develop to support their communication with local decision makers who may not be as familiar with health economics?
Okay. I don't know if I've got those soft skills, so I might say the wrong things, but I think talking to people, understanding what's important to them, and especially what kind of messages lands with them, and also lands with, so local authorities, they might have to influence councillors. Councillors might be from different political persuasions, so understanding what kind of messages they're sensitive to and what will land with them, I think is really, really important. I think just spending the time to understand what's important to them, and also what schedule they're working on as well. So if they need to make a decision in 2 months' time and you give them the evidence in 3 months' time, it's no good, is it? So I think ensuring that what you do is timely enough to help as well. I don't know if any of that was really soft skills, sorry. But...
did you have another one from online? Yep. Yes.
Do you have any insights on how to embed health economics into local decision making where staff change continuously? And how can you change the culture to create a legacy beyond the specific people?
Yeah, it's really tricky. I think probably, I mean, it's like, I suppose it's like with anything that you've got within an organization, you need to have some way of keeping the organizational wisdom over time. So whether that's through senior people who might stay there for longer, or having training packages and things like that people can use, or analytical tools that people can adapt over time. But yeah, I think it's really tricky. I think if we want there to be more health economic skills in local government, etc., then maybe more of those training packages need to be developed so that the basic skills can stay there over time.
You've moved around yourself quite a bit and back in and out of the same situation as well. Have you found when you've re-entered a situation that there's any kind of persistence from what you were doing before, or the same people around, or do you find that things have changed quite a lot and you're starting from scratch in some places?
Yeah, it's a mixture. I think there's some things where with other colleagues we started it, so like multi-criteria decision analysis for prioritization. There's some areas that are still doing that many years later, which is good. So, but I think other places, if you lose the people with those skills in terms of modelling or health economics, it can be hard to replace them. I think that, you know, health economics exists in quite a mixed marketplace, don't they? So people can go and work in big pharma and things like that. So there's a draw from different places.
The question in the room, Ryan?
Hi, Karen Bloor, University of York. I wonder how you balance usefulness and timeliness against robustness, really, and how you kind of make that judgment. I suppose I'm thinking particularly about your social return on investment. I've just done a rapid review, so not very systematic, but looking at return on investment and cost benefit analysis for things related to the public health grant. And you find when you read the papers that the cost benefit analysis, cost utility analysis tends to be done alongside a trial. Social return on investment tends to be a modelling exercise, and sometimes, you know, outright guesswork. Yeah. So which one's useful in that case, and how do you make a decision about which one you use, because they often give you wildly different advice, I think. Yeah.
Yeah, I think it has to be a bit kind of buyer beware with social return investment. I think you do need to kind of scratch the surface sometimes to see how robust they are, and sometimes they're not very robust in terms of particularly considering the overlap between different outcomes, or how the evidence change in outcomes, or the financial value they put on things. So something you see quite a lot is people felt more confident, so we put a value of 800 quid for competence training or something like that. So which I've been guilty of myself as well, I must say. But I think there are those kind of issues around overlap and how they evidence. Yeah, so I think it's possible to do really good social return investment, and I think it could be something really useful. And it's probably similar to you know, cost consequence analysis, or impact inventory that we would use in health economics. So trying to list the impacts, but you still need to think about what the overlap is between those different impacts if you put in a financial value on them. And I think sometimes a lot of that is guesswork, like you say.
Do you know if there's any signifiers or anything that people that you've worked with in local authorities or NHS or government might use to try and distinguish between a good and a bad quality evaluation? I guess if there's a lack of skills to be able to interpret it directly and they're presented with the headlines, is there any kind of, I don't know, filter or triage or preference for information from one source over another?
Yeah, I think those skills don't always exist. Maybe some places they do, but I suppose people who do the public health training will be, so the public health consultants, they will do a lot around evidence. And I think public health consultants are increasingly working across different parts of the local authority to help around evidence. But beyond that, I think it will vary quite a lot in terms of people's ability to understand the robustness of different evidence that they're presented with. Yeah, definitely.
I guess within academia, we kind of see the peer review process as like quality control mechanism, but from what I hear from other places, that actually there's no interaction then between the policymakers and that peer review literature necessarily. So that all that quality control within that is maybe redundant if there's SROIs and stuff popping up everywhere from all kinds of sources and it looks the same.
Yeah.
As the.
Yeah, I mean, there is a kind of peer review process for SROI as well, and they can get like accredited and things like that. So I suppose that it is possible people become accredited practitioners. So there is a bit of peer review for that, but I do agree that that there is an issue around different types of evidence and the weight that you put on those different types of evidence.
So Joe Spearing, University of York. I was wondering if you had a view on how the opportunity for health economists to positively influence government policy on prevention has been changed by, I mean, basically getting a new government in who seem to be putting a lot more emphasis on prevention, like going further on the smoking legislation than this health MOT thing. Do you think that's changed the opportunity for health economists? And if so, how can they properly exploit it?
Yeah, I'd say yes, it has, hopefully. Yeah, so hopefully there's more opportunities around prevention and influencing governments. I don't know how to get in there. I suppose like if you've got contacts in DHSE and places like that or OHIDs, then that would probably be your way in to influence those things. But yeah, I'd say I hope so. Yeah, I think we'll know more in 3 years' time if they've really kind of gone big on prevention. But hopefully there is that opportunity. I think working in Welsh Government, there's a lot of things that we've done in Welsh Government, like 20-mile-an-hour limits, universal basic income trial for care leavers, universal free school meals for primary schools. So there's things that have been tested in Wales that I think could potentially, minimum unit price for alcohol as well, that could potentially be transferred to England as well.
So just going to wrap up now and just ask everyone to first thank Brendan for his talk. That was very interesting, lovely to hear. And just to let you all know that the next in this series will be given by Matthew Taylor, who's Chief Executive of the NHS Confed, and that will be on Wednesday, the 15th of January at 2 o'clock. So please do come back and join us for that. And for more information, please do visit our website, as you can see here, and you should see some adverts about that event coming soon. So thank you, everyone. For those who are here in person, please feel free to stay and join us for some drinks and nibbles. And I'll say goodbye to the rest of you online.
Thank you.